Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anish Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about multiple myeloma with Dr. Natalia Neparidze and Kathy Giusti. Dr. Neparidze is an associate professor of internal medicine and hematology and research leader of the myeloma program at Smilow Cancer Hospital. Kathy Giusti is a cancer patient advocate and author, and Dr. Chagpar is a professor of surgical oncology at the Yale School of Medicine.
So maybe we'll start off with each of you telling us a little bit about yourself and what it is you do. So Natalia, maybe we'll start with you. Tell us a bit more about yourself.
Thank you. I've been on and off at Yale since 2003. I completed most of my training here, including research training, then residency and fellowship, and then joined the faculty in 2012 as a hematologist oncologist, and I currently serve as an associate professor and lead some of the research operations with myeloma program.
Excellent. And Kathy, how about yourself? Tell us a bit more about yourself.
Yes, my background is actually originally in the pharmaceutical industry, where I worked for Merck, and then moved on to business school and went back to the pharmaceutical industry where I worked for Searle. And I was 37 and handling worldwide operations for Searle when I was diagnosed with multiple myeloma. And that's when I had to move out of my corporate job, and I ended up starting the Multiple Myeloma Research Foundation in 1998.
Fantastic. Well, so just to give us a little bit of background, Natalia, can you tell us what exactly multiple myeloma is and how common it is, how people get diagnosed?
Of course. So myeloma is a type of blood and bone marrow cancer. It is the second most common blood cancer after non-Hodgkin lymphoma. So overall lifetime risk of developing myeloma is on the order of 1 in 100 persons approximately, and with a total of newly diagnosed cases on the order of 38,000 per year in the United States. So it's not very common, but there's a large population of patients that live with myeloma in the United States. So myeloma develops from a type of white blood cell called plasma cell, and plasma cell is an important immune cell, and it is responsible for producing immune antibodies that help you fight infections. But when a plasma cell becomes malignant or abnormal or cancerous, it can lead to full-blown myeloma. And initially, myeloma can be completely silent, like in its precursor state of monoclonal gammopathy or smoldering myeloma. And patients, when they present, they may have very vague, subtle symptoms, or it could be completely silent. Symptoms may consist of subtle symptoms like fatigue, unintentional weight loss, frequent infections, bone pain, back pain, at times neuropathy like numbness and tingling, at times with change in urination. And other times it's silent but may get picked up by routine blood work if it's performed by primary care physician. It can show up as low blood counts on a complete blood count. And if complete metabolic panel is obtained, you may note high protein level, high globulin level, and suppressed albumin level. And at times, people may present with unexplained bony pain, and something gets picked up on X-ray, and that's what leads to the diagnosis of myeloma.
Wow, it sounds like it's pretty nonspecific. I'm sure all of our listeners can think, well, geez, I've been kind of tired. I can get a little bit achy. And so to think that those kinds of nonspecific symptoms or even no symptoms at all could lead to a diagnosis that sounds pretty scary, it is a little unnerving. So, Kathy, maybe you can tell us a little bit more about your journey. How was it initially picked up for you?
It's such an interesting story, and I do cover it in the book, but you have to remember this was back in 1996, even before the internet. And I was basically trying to have another child. And so they explained to me that in order to get referred on to a fertility doctor, I needed to see my primary care, my internist. So I headed over to him, just unsuspecting of anything. And he did a routine blood test on me. And then he asked me to repeat the blood test. And even then, I wasn't really thinking twice about it. Went in, had them repeated. And after that is when my husband actually took the call from our internist saying that he suspected some things were unusual and that he wanted my husband and I to come in and see him together. So at that point, I kind of knew that something was up. The really interesting thing about the story, though, is back then, primary care and internists were not really super aware of multiple myeloma. And the reason that I was on his radar, because multiple myeloma skews older, male, and African American. So me as a young woman, white woman, was not typical. But he had another patient that was another young woman before me. And I think he was just really in the know of having gone through a differential diagnosis with her. And so there was a little bit of a really good doctor, a really good internist working with me, but also just a bit of serendipity in terms of him being so aware of myeloma and the fact that it's not just in older men that are African American. And then going back to where we are today, I think there's been so much more awareness of myeloma. We've made so much progress in the field. And as a result, just as the doctor said, it's interesting, but I think we're getting so much better at finding it earlier, whether it's an early stage like MGUS or smoldering, and the ability to find this disease much earlier by the internists and primary care doctors is really a gift to the patient because you always want to be found early.
So, Natalia, maybe you can break down some of the terms that Kathy has been using. What exactly is MGUS and smoldering multiple myeloma, and how is this found early? I mean, if somebody has a low blood count, for example, on a routine blood test, what happens then? How do we pick this up early, and how is this ultimately diagnosed?
Of course, yes. Myeloma diagnosis requires a little bit of a detective work. In other words, diagnosis is not delivered to you on a tray. So it does take certain diagnostic workup, which consists of series of blood and urine tests. I would like to stress the importance of, for all adults, to have a primary care physician, to have at the very least complete blood counts and comprehensive metabolic panel checked at least annually. And these may give some hints about the early diagnosis in the form of elevated globulins, elevated total protein. And I think it's important for the primary care clinicians to be cognizant of these subtle changes, to be able to then conduct stepwise workup, which includes the standard diagnostic tests for myeloma or MGUS with protein electrophoresis, immunofixation, and some of the free light chain assays, urine tests, as well as imaging. And this is usually done stepwise. And ultimately, the diagnosis, if index of suspicion is high, the diagnosis is confirmed by performing bone marrow biopsy. I should mention that there's no screening that's approved for myeloma currently. A number of groups of researchers are currently investigating the role of the screening and how to apply it to the high-risk populations. So this is still very much a research subject, but I certainly stress the importance of early diagnosis because we know that myeloma, every case of myeloma is preceded by a precursor silent state. And the first precursor state is something we call monoclonal gammopathy of undetermined significance, which is referred to as MGUS, abbreviation, MGUS. And many people just develop this in their adult life, and nobody really knows why. And a fraction of these patients will proceed to develop a higher burden of this plasma cell disease, which arbitrarily gets defined by bone marrow percentage of plasma cells. And if they have greater than 10% involvement with these clonal plasma cells or cancerous cells, that by definition leads to the diagnosis of myeloma. And then it requires the next stage of workup with the incorporation of advanced imaging, such as whole body PET scan or whole body MRI, and other tests on bone marrow, including cytogenetics, FISH, molecular studies, to really define the disorder, define the stage, define the whether there is organ involvement or not. And I should mention, when myeloma is a full-blown disease, It can involve bones, creating bony deposits like metastases, leading to pathologic fractures. It can involve kidneys, leading to kidney injury. And it can involve, obviously, heavy involvement of the bone marrow will lead to low blood counts. There's also a very high frequency of infections. So this is a general summary of initial diagnostic steps.
Yeah. So Kathy, you went to your internist because you needed to go to your internist in order to get a fertility referral. And something showed up on the blood work. Can you tell us a bit more about what showed up exactly? And then how were you worked up? I mean, you mentioned that your internist had a very high degree of suspicion, but was this caught in the stage of MGUS? Was it full-blown myeloma? Did you have to go through a bone marrow biopsy? Tell us a bit more about what exactly happened and how you and your husband were feeling as you went through that process.
Yes, by the time he called me, and again, I was, driving back from work and I was waiting for the phone call because I'd missed him. And I remember thinking to myself, because he said, you have to come in together, that it was obviously going to be something bad. I grew up in a medical family. My father was a physician, so I knew enough to think, if he has us both coming in, something's going on here. And so basically what, he explained to me on the phone call was exactly what we discussed earlier. He saw the elevated protein, which was a real giveaway because he had done additional testing on that. So he could actually see, what protein was high and what was going on with it. The blood counts were off. I was, very anemic. So that was another signal for him. So there was enough going on there that he had suspicion. But at that same point, when I came in to see him, at that point, you have to be referred on to a hematologist oncologist. And for people that aren't, living and breathing in the medical community, you now move from your primary care doctor to, this word salad of different doctors that you have to get to. And so it's get to the hematologist oncologist. We need to get you through a bone marrow. We're going to send you over to the pathologist. Depending on what we see there, we're going to potentially go to the radiologist. And so you have to really sit down and go through all these different pieces before they can formally diagnose you. As discussed earlier, it's a bone marrow biopsy that really helps along with the imaging. And in the bone marrow biopsy, they were able to see the percent of plasma cells and understand that indeed I did have multiple myeloma. But it's never like there's a black and white. There's always this area of gray. So for someone like me, my proteins were high. And so that would have made them think I'm more like a stage 1 patient, not a smoldering patient. And yet my imaging was clean. So that made them think another thing. And then my bone marrow was on the bubble of smoldering versus stage 1. So it's not always easy to know exactly where you are. What I ended up doing after a number of second opinions in the local Chicago area was I realized that the Mayo Clinic was doing really good work in smoldering multiple myeloma patients specifically, and that they had a really good database on those patients. So at that point, I took the initiative with my husband and headed to the Mayo Clinic and had an entire round of testing done there, where I think I was there for 2 or 3 days. And that was when we determined that indeed it was smoldering. But it takes time. It really takes time and a lot of tests.
So we're going to pause the story there. But we need to take a short break for a medical minute, but please stay tuned to learn more about Kathy's cancer journey with multiple myeloma and the rest of the story right after this.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their cancer genetics and prevention program includes a colon cancer genetics and prevention program that provides comprehensive risk assessment, education, and screening. SmilowCancerHospital.org. The American Cancer Society estimates that more than 65,000 Americans will be diagnosed with head and neck cancer this year, making up about 4% of all cancers diagnosed. When detected early, however, head and neck cancers are easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for head and neck cancers. Yale Cancer Center was recently awarded grants from the National Institutes of Health to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, or SPORE, to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immune, DNA-damaging, and targeted therapy. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anees Chagpar, and I'm joined tonight by my guests, Dr. Natalia Neparidze and Kathy Giusti. We're talking about multiple myeloma and Kathy's cancer journey. Now, right before the break, Kathy was telling us about how, she really didn't have a whole lot of symptoms. She didn't fit the classic type of multiple myeloma patient in terms of being older, male, African American. She's young, Caucasian, and female. But her internist had found abnormal protein levels on a CBC, on a complete blood count. And we heard from Natalia that it's really important to get that at least once a year. Now, Natalia, I want to pick up the conversation with you because right before the break, Kathy started talking about, how the doctors were trying to figure out whether this was, quote, smoldering or whether this was stage 1. Can you help our listeners understand what exactly is smoldering and how is myeloma staged?
Thank you for those questions. I think this is an evolving field, and what we might use as descriptive terms for smoldering would have been different 10, 20 years ago compared to what it is now. So the field is evolving. But just for the listeners, I would say that MGUS is a relatively benign indolent state, and it may or may not evolve into anything. Once there is a diagnosis of smoldering, which by definition currently requires the presence of at least 10% or more clonal cancerous plasma cells of myeloma in the bone marrow, then we have the diagnosis of myeloma. Then the question remains, is this case smoldering, meaning not causing organ damage or fragility fractures or other events, or is this a full-blown disease rather than a smoldering disease which requires active treatment? So definition of smoldering currently is subdivided into the high-risk smoldering based on number of blood markers. We include cytogenetic or genomic markers, which are done on the bone marrow to define whether there is a high risk versus low risk of progression over the course of first 3 to 5 years. And smoldering myeloma diagnosis cannot be established unless one obtains a full-body imaging. You want to make sure that there is not a target organ damage in the form of either kidney injury or skeletal injury. And once it is ensured that there are no bony destructive lesions attributed to myeloma, and if the kidney function is normal, if blood counts are largely normal, there may be a small amount of anemia, but unless there is a significant drop by 2 or more grams of hemoglobin, these criteria are consistent with smoldering myeloma. Then we try to, based on cytogenetic, genomic markers, identify patients that are at high risk of progression from smoldering to active clinical full-blown disease of myeloma. And this is a complex process, and there are certain risk stratification criteria which subdivide patients into a high-risk smoldering versus low-risk smoldering. And if the risk of progression is low, some of the patients with smoldering myeloma may still be observed. However, there is this notion that just like in cardiovascular disease, you wouldn't wait until a person has a myocardial infarct or heart attack before you treat high cholesterol or hypertension, high blood pressure. So too in myeloma, if you have a well-defined precursor state, you don't want to just sit on it and continue watching and treat the person only after end organ damage happens. So there is this increasing notion of intervening early as a preventive strategy. So we now have well-established guidelines to treat those patients with myeloma, smoldering myeloma, who actually have high-risk genotype or some of the clinical criteria that describe them as high risk. So we now are able to give them several either investigational clinical trial type of treatments or alternatively well-established study with lenalidomide, which is an immunomodulatory drug.
So, Kathy, you had decided with your husband to go and get another opinion at Mayo Clinic, leave your hometown of Chicago. Can you talk a little bit about that decision? It seems to me that, some patients might be thinking to themselves, how would my doctor feel about that? Did you have those same kinds of hesitations? And why did you ultimately decide to seek a second opinion? And what advice do you give people who are making that decision?
Well, first of all, I think it's critical that you get a second opinion. So, what I explain to patients is that when you get the diagnosis, and I do cover this part in the book too, when you get the diagnosis, it's really a time that you have to sit down and say immediately, what are your needs? And for a lot of people, those needs may be, my insurance is through my job. I have got to get to work every day. I have to get my kids to school. My parents are sick. There are a whole list of these immediate needs that you have to face. And then I always explain to people at diagnosis too, there may be something else that is lurking even deeper in you, which is what are the wants? And as you read in the book, a big want for me was to have another child. And I know that sounded kind of crazy, but to be honest with you, I had been told I would live just 3 years with multiple myeloma. So I felt like if I was willing to take that risk, it was something that was really important for me to do. So I think that finding the centers that can help you the most is the most important part of the early part of the journey. So for patients, once they write these needs down, it will help them to understand, are you going to the community hospital nearby? And if so, that can be fine. You just want to make sure you're getting to the community hospital that sees a lot of patients like you with that specific cancer that you have. If you can, it's always amazing to get to an academic center, more of the teaching hospitals, because that's where they're doing more of the research and they have more of the clinical trials and just more experience with a higher volume of patients. And then the third area is you can get to one of the NCI designated cancer centers. There are over 70 across the country. So my recommendation, and I cover this in the book, is that when you go to get that second opinion, and often if you have a really good local oncologist, they're not going to be upset that you're getting a second opinion. They're going to applaud you for doing that. And they may even give you some really good places to go. When you actually get that second opinion, it may be that you really like that academic leader. And it means that you can still create a team. You can always have someone who's at an academic center helping to call the shots on your overall treatment plan. But you can also then have that person working directly with your community oncologist. So you don't have to keep driving a long distance to get your treatment, especially if you're working and it's really hard. So my advice to patients is, if at all possible, you're starting to develop your team. If you can, try to get to an NCI designated cancer center, an academic center for your second or third opinion. It should be covered by insurance, so you want to make sure of that. And then create a team that you really like with your local hospital where they can help execute on the care.
Yeah, such good advice. Natalia, can you talk a little bit more about what the treatment actually entails, perhaps some of the clinical trials that are currently ongoing for multiple myeloma, and what the prognosis really looks like? I mean, Kathy was told that she had only 3 years. Is that standard, or are we actually looking at survival rates that are much longer than that? I mean, Kathy is now at least a couple, if not more decades from her original diagnosis.
Yes, this is wonderful, and Kathy's story has inspired many individuals around the world, and it's really commendable what she did. That's the historical reality. Back in 20 years ago, we really didn't have many drugs for treatment of myeloma, and the survival historically ranged between 3 to 5 years from the time of active diagnosis. However, at this point, we are fortunate that treatment has advanced to the point where most of our individuals with diagnosis of active myeloma are able to live more than 10 years, sometimes 15 and up to 20 years with active myeloma requiring treatment. And this is thanks to some of the Kathy's efforts through Myeloma Research Foundation, for which we're really extremely grateful to her. These efforts and efforts of many investigators have led to the development of drug classes like proteasome inhibitors, like bortezomib, carfilzomib, immunomodulatory drugs like lenalidomide, pomalidomide, and others. And more recently, these immune-targeted therapies like monoclonal antibodies, the CD38 monoclonal antibodies like daratumumab or isatuximab, which are able to directly target myeloma cells to kill them and eradicate them. And additionally, more recently, we are more and more employing other targeted immune therapies like T-cell redirecting, bispecific antibodies, antibody-drug conjugates, and finally, more recently, CAR T-cells, which have been FDA approved. So to summarize, once we establish that a person with a newly diagnosed myeloma has active disease and requires treatment, and that's determined by presence of either active bony lesions or kidney disease or the development of anemia. In younger individuals, the care usually consists of combination of 4 different drugs, including some of these novel monoclonal antibodies, the CD38 monoclonal biologic drugs that I recently mentioned, in combination with proteasome inhibitors, IMiDs, and steroids. And in appropriate younger, healthier individuals, after several cycles of this, what we call induction, which is usually about 4 to 6 months worth of treatment, we then proceed with a high-dose melphalan stem cell transplant, usually. Various combinations have been tested over the years. And after transplant, we invariably continue treatment with some of the targeted agents. It will depend on, currently this area is evolving, and we would apply different strategies for maintenance based on the patient's individual profile. And treatment for the elderly patient consists of combination of some of the same drugs, either with 3-drug or even 4-drug combinations, depending on their clinical profile. And with the exception that older patients over age 75 or 70 may not be ideal transplant candidates. So we would do the same treatment strategy with maintenance and ongoing continued maintenance to maintain the remission in elderly population as well.
Yeah. Kathy, as Natalia kind of gave us that broad landscape of all of the treatments that have evolved over time, it really brings back this whole concept of research. And I want to talk a little bit about the Multiple Myeloma Research Foundation that you founded. Many patients go through a diagnosis. Very few actually start a foundation. Can you talk a little bit about what the foundation is and how you created it and what it's doing?
Yes, so I started the foundation in 1998. I was very fortunate in that I was working in the pharmaceutical industry for Searle at the time, which is now part of Pfizer. And as a result of my diagnosis, everybody wanted to raise funds and really help. And I didn't have anywhere to put those dollars. So my sister and I started the Multiple Myeloma Research Foundation, and it quickly took off. The entire goal for us from the very beginning was to focus on new treatments for patients. So we always started strictly for research.
Kathy Giusti is a cancer patient advocate and author, and Dr. Natalia Neparidze is an associate professor of internal medicine and hematology and research leader of the myeloma program at Smilow Cancer Hospital. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.